Yeah, thank you very much. So I think it was relatively easy for me now to give the counterpart, because if you look for the talk from Dr. O'Neill, has he shown any randomized clinical trial for patients with mechanical circulatory support? I missed it in his presentation. And this is my disclosure. My major disclosure is I believe in evidence and I follow evidence, and evidence, the highest evidence, is randomized clinical trials. And this is what I will try to show you with respect to mechanical circulatory support. So this is what we have available, at least in Europe. You all know these devices, IABP, Impella, Tandem Heart as well. And we also have in Germany and in Europe the IVEC 2L. And for sure, we also have ECMO. You have seen this. Probably in my life, I've shown this slide several hundred times. But if you would have asked me in 2012, I was also a believer in the intra-aortic balloon pump, and also our ethical committee said you can't do a randomized trial where you treat patients without an intra-aortic balloon pump. And it took us a year to convince the ethical committee to do this trial, because everybody was believing in the intra-aortic balloon pump. But as you now can see, the intra-aortic balloon pump has no effect at all. And that's the reason why, at least in the European guidelines, we now have a class 3 recommendation that the intra-aortic balloon pump should not be used on a routine basis. In Europe, we follow more evidence, so we do not use the intra-aortic balloon pump in 40% of the cases anymore. So in Germany, it's down to less than 5%. And it's mainly used by the surgeons, but not by interventional cardiologists anymore. And you can see what our trial has, how our trial has influenced the clinical practice. These are US data. So intra-aortic balloon pump is going down, and you have the steep increase in Impella, Tandem Heart, and also ECMO use. And this is what happened in Germany. So a very steep increase in ECMO use, which is maybe also influenced by reimbursement. And also because we have seen that the intra-aortic balloon pump does not work. And now we really want to have something which is more active and which hopefully will lead to a reduction in mortality. But now we are looking for evidence. So this is important. So currently we have 4 small randomized clinical trials comparing Impella or Tandem Heart versus intra-aortic balloon pump. And we were able to do an individual patient-based meta-analysis. And this is what you can see it here. I agree, this is limited because we have only 150 patients, but there's really no effect at all on mortality if you use active mechanical circulatory support versus intra-aortic balloon pump. And maybe most importantly that you have to look on this. There's an increase in the mean arterial blood pressure if you're using active mechanical circulatory support. There's also a small but significant decrease in arterial lactate, at least immediately in the cath lab. But you also have more bleeding, as you can see it here. And I have learned, and I know it from many registries and trials, bleeding increases mortality, and we can't ignore this effect. So these devices increase bleeding, and this is what we have to keep in mind. So in the moment when we do not have large-scale randomized trials, usually what we do is we use registry data and we try to do matching, which is not perfect, but it's at least the best what we can do if we do not have enough randomized data. And I will show you the data. So the large-scale matching studies, this is one we have done from IABP Shock 2, comparing it to an Impella registry. Looking for this, no effect at all on mortality, but significantly more bleeding, more peripheral complications, more life-threatening severe bleeding, and also more sepsis with the active mechanical circulatory support. Then you all know these highly discussed registries from the United States. 28,000 patients, 48,000 patients, and they try to adjust it. They try to do matching. More deaths, more bleeding, more acute kidney injury, more stroke with Impella in comparison to intra-aortic balloon pump. And then you also have this registry published very high in JAMA, as you can see it here. Altogether, 3,300 patients have been matched in this, this comparison. More deaths, once again, more bleeding with the Impella in comparison to control. In this case, they use the intra-aortic balloon pump. So based on this, currently I can't see any registry and I can't see any randomized clinical trial which has shown a reduction with active mechanical circulatory support for patients with cardiogenic shock. Looking for ECMO, this is what we do in Germany. Registry data, we have some data there, but it's very, very limited. This is a meta-analysis where there may be a reduction in mortality if we are using ECMO in comparison to control, but very limited, less than 100 patients so far. Taking all the things together, and this is what I mentioned, I believe in evidence, I believe in randomized clinical trials. So early revascularization can reduce mortality based on the shock trial in patients with acute myocardial infarction and cardiogenic shock. Everybody probably also would not have believed that culprit lesion only PCI, so the more minimalist approach will reduce mortality in patients with multivessel coronary artery disease, as we have shown in the culprit shock trial. And now hard evidence, pure evidence, intra-aortic balloon pump does not reduce mortality. And if we are using active mechanical circulatory support in an unselected way, and this is probably what Dr. O'Neill is currently doing, then we will not be able to show a reduction in mortality. And this is maybe the most important slide. We are also using active mechanical circulatory support in Leipzig, but probably patient selection is key. If you put in a device in every patient, and we currently know that 50 to 60% of the patient will survive without any device. But if you put in a device in this patient, you will not change the outcome of the patient. Or maybe you will induce harm, and you maybe will induce bleeding. You may also induce other complications which will lead to death of the patient. And I've seen these patients in clinical practice. Honestly, I believe that maybe 20-25% may have a benefit of active mechanical circulatory support. Then there are also patients who are in a futile situation. You can put in the best device in the world and you will not change the outcome. In particular, those patients who have undergone resuscitation before. And these are currently roughly 50% of the patients getting into our cath labs with acute myocardial infarction and cardiogenic shock. This is what we called cohort A, no device. This is what we called cohort B. Yes, a device should be used. And this is where you can discuss at least to use the device as a bridge to decision until you know the neurological outcome of these patients after approximately 3 days after admission to the intensive care unit. The good news is we have ongoing randomized clinical trials which will give us the answer if we are really able to reduce mortality for patients with cardiogenic shock. In blue, you can see the already performed randomized clinical trials. In red, you can see the ongoing trials. We are currently doing an ECMO trial, ECMO versus no ECMO for patients with cardiogenic shock. And I've just seen the interim analysis, so now we have included 225 patients. From now on, it will take us approximately maybe 1.5 years. Then I can tell you if ECMO in severe cardiogenic shock patients will be able to reduce mortality. There's another European trial, which currently has included only 20 patients. Then we also have the DANGER trial, the Danish Germany trial, randomizing patients to Impella in comparison to control. They are still struggling with the inclusion rates, and they have, so far I know, nowadays included a little bit more than 210 patients. So this is also an important trial, but we need this evidence to really can say, okay, active mechanical circulatory support is able to reduce mortality for these patients. Thank you very much.
Thank you, Dr. Thiele. Really, really great discussion. And, your that second to last slide is really the slide. And I think like you're basically saying the same thing that Dr. O'Neill is saying, that what he's trying to do is because it's hard to identify who are those patients in the right side of the panel. And you didn't tell us that. So what I think Dr. O'Neill is saying is that if we apply it to most cardiogenic shock, you will get some benefit from that bucket of patients that you just described as the patients where we could see a benefit. Can you?
I think we're saying the same thing. If you have a really low-risk patient, you're not going to have much benefit. And at the other extreme, the patient's probably futile. It's just trying to find the sweet spot. But what we've been trying to do for the last 4 years is to really optimize the use of Impella in cardiogenic shock. For instance, 40% of the patients have severe RV dysfunction. if you use Impella, just the left-sided Impella alone, and don't do anything for the right side, you're going to have a futile outcome. And nobody knew that 5 years ago. So I think we have a very good algorithm now that we're going to ultimately test. Because if we get it wrong and it does work, it's going to take another 20 years to figure it out.
Dr. Thiele?
Yeah, it's difficult to say which patient really have a benefit. It's currently what we do, at least in the cath lab or in the ICU, it's a gut feeling. So often we look for lactate, but I also looked it up, what was the age in all the randomized trials and also in the registries. Usually the age is in the range of 60 years. This is what we also have to keep in mind. And all the randomized, large-scale randomized trials, like IABP Shock 2 and also Shock, the median age of the patient was a little bit more than 70. So what we currently do, we do already a selection in these patients. So we are treating the younger patients with active mechanical circulatory support in clinical practice. So most of the patients who come in currently are much older, and probably this is what we already do in clinical practice, that we do not use active mechanical circulatory support in these patients.
This is great. I can't wait for these trials to come out because I do believe the randomized trials will give us some answers.